Thank you very much. Hello, everyone. I'm introducing you to Siobhan Lock. She is a second-year PhD student, has a psychology background, and came to us thanks to the support of Mental Health Research UK through a master's in bioinformatics. I hope you will appreciate how Siobhan's research is trying to integrate what traditionally would be two separate research programs, a biological research program and a psychological psychiatry research program, into something that we think could be very meaningful for questions that are hugely important for people with experience with experience of psychosis related to symptoms and cognition, and that are sometimes relatively unexplored into the more biological or genomics literature. So Siobhan, over to you.
Cool, thank you very much. Okay, so hi everyone, I'm Siobhan, and my PhD project is about exploring genetic data and electronic health records to see whether they can be used to predict treatment outcomes in people with schizophrenia. So schizophrenia is a chronic psychiatric disorder affecting about 1% of the population. It is a leading cause of disability and is accompanied by a heightened risk for physical and mental health problems, unemployment, and suicide. The presentation of the disorder can be pretty varied, which makes schizophrenia a real challenge for clinicians to treat. The disorder is usually treated with pharmacotherapy in the form of antipsychotics, potentially alongside a form of psychological therapy like CBT or family therapy. These drugs target neurotransmission in the brain in hopes of reducing mainly the positive symptoms of the disorder. Unfortunately, however, response to these drugs is variable and in a third of cases might not produce any benefit at all. So with that in mind, the aim of this project is to look at whether different medication and pharmacogenomic variables predict symptom severity in people with schizophrenia. And we hope that this will be useful within the field of personalized medicine, which aims to deliver effective pharmacological treatment quicker than could be achieved through current approaches alone. So for this study, we used participants from the Cardiff COGS cohort, which is a really big group of people recruited from secondary mental health services in the UK, however, primarily based out of the Cardiff and South Wales area. So thanks to everybody involved, we have a really big database of detailed phenotype and genetic information. And for our analysis, we were only interested in people with schizophrenia or schizoaffective disorder depressed type. The two disorders both share similar symptoms and crucially are both treated with antipsychotics. So in all, we took through around 595 people with these diagnoses and with the relevant medication and genetic information available. So for the data analysis, I used 3 different techniques, and I'm just going to briefly outline them. So first up, we've got CFA, or confirmatory factor analysis. And this is a tool that helps us to understand how different variables relate to different concepts. We had 14 different variables, each measuring different facets of schizophrenia symptom severity. And we use CFA to group similar items together, and in doing so, simplify this complex data into 5 main phenotypes. This is what the structure looked like with our raw variables on the bottom, loading onto our latent variables on the top. And we use these variables as the outcomes in our analyses. Next up, we've got polygenic scores, which are measures of genetic risk towards a given disorder or trait, calculated by adding up the effects of all of an individual's variants that confer risk to the trait of interest. Higher scores reflect higher liability to the trait, whereas the opposite is true of low scores. But crucially, these do only represent genetic risk, and it doesn't necessarily mean that you'll go on to develop a disorder or trait or phenotype if you have a high polygenic score. So we calculated this for schizophrenia, as well as for IQ, clozapine and norclozapine metabolism, And we included these variables across some of our models. And then finally, we've got pharmacogenomic allele calling. The idea of pharmacogenomics, which is often abbreviated PGX, is to understand how genetic variation might influence response to drugs. Often this variation can result in a change to enzyme function, leading to faster or slower metabolism of drugs relevant to that enzyme. We looked at that variation and then assigned activity scores to each person for each enzyme, where lower scores represent slower activity and higher scores faster activity. And this is an overview of what we did then. So first, we fit our initial model on the total sample, so 595 people. And then we divided our sample into clozapine users and non-clozapine users and repeated the analysis. We did this because we know that clozapine is a pretty unique antipsychotic, both in terms of how it works and in terms of who it is given to. We've also previously seen evidence of an interaction between antipsychotic dose and clozapine use in this sample, suggesting that the effect of dose on symptom severity differs by whether people are taking clozapine or not. Then finally, where we saw an association between antipsychotic dose and symptom severity, we wanted to go a step further. We added in pharmacogenomic variables because they have the potential to impact upon drug metabolism, and so they might mediate some of the associations that we've seen between drug dose and symptom severity. First, we tested the following medication variables against each outcome, where the outcome variables are the factors that we derived from our confirmatory factor analysis. So we had daily antipsychotic dose, current clozapine use, and anticholinergic use as our medication variables. And then we included age, sex, schizophrenia polygenic score, and medication adherence so that we could account for the impact of these variables within our model. And we observed the following associations. So as antipsychotic dose increased, so did scores on the positive symptom dimension. This means that higher doses were associated with a greater severity of positive symptoms, such as hallucinations and delusions. Next, clozapine use was associated with both of the negative symptom domains. And in each instance, use of the drug was associated with more severe current expressivity and motivation and pleasure-based symptoms. We also saw that anticholinergic use was associated with more severe motivation and pleasure symptoms too. And finally, none of our variables were significantly predictive of the depression and suicide dimension. So next, we saw that a few of our variables were in fact associated with cognition. As with the positive dimension, we saw that increased antipsychotic dose was associated with more severe cognitive symptoms. Equally, use of clozapine and anticholinergics were both linked with reduced cognition too. So our two main findings from this part of the analysis are that increased dose is associated with more severe positive and cognitive symptoms. And while the results sound similar, they probably arise through two different circumstances. The association with a positive dimension is likely to be because clinicians are treating people who've got more severe symptoms, more severe positive symptoms, with higher doses of antipsychotic. This probably wouldn't be happening with cognition, as cognition is not really the primary target, primary therapeutic target of antipsychotic medication. So in this instance, it's probably that higher doses of antipsychotic are impinging upon cognition in some way or other. So with that in mind, we next did our subgroup analysis. And while this does reduce our sample size a little bit, it also shows some interesting results. So within the positive dimension, we only saw our association with dose in non-clozapine users, whereas the opposite is true in the cognition dimension, with the association only apparent in clozapine users. So now we want to go a step further and add in into First, we added in our pharmacogenomic activity scores to the model, and then our polygenic scores for clozapine and norclozapine metabolism. We only incorporated relevant variables into our model. So for clozapine users, we used the full complement of enzyme activity scores and metabolism polygenic scores. But for non-clozapine users, we only used CYP1A2, CYP2D6, and CYP3A5 activity scores because these enzymes are responsible for the metabolism of most antipsychotic drugs. And we fit these models where we previously saw dose dimension associations, so within the positive dimension in non-clozapine users and with the cognitive dimension in clozapine users. So we didn't see any pharmacogenomic associations with the positive dimension, but in the cognition dimension, we did see a positive association with CYP1A2 activity score in our clozapine users. So what this association means is that increased CYP1A2 activity was linked with better cognition. CYP1A2 is one of the most important enzymes involved in clozapine metabolism. Therefore, high CYP1A2 activity would result in the faster metabolism or clearance of clozapine to its metabolites. We've already seen that increased clozapine dose is associated with reduced scores on the cognition dimension, or in other words, poorer cognition. Therefore, this association with CYP1A2 activity score makes sense, as faster enzyme activity means that clozapine is metabolized and cleared more rapidly, and thus there's less clozapine around to impinge upon cognition. So in conclusion, we found associations between medication and genetic predictors with distinct domains of schizophrenia, which adds to our current knowledge as to the effects of pharmacotherapy on schizophrenia symptoms. One of our key findings was that antipsychotic dose was associated with the positive and cognitive symptom domains, where higher doses was associated with increased severity of these symptoms. We also identified a genetic predictor for cognition in clozapine users, and these findings could be important given that cognition is one of the most important indicators of functional outcomes in schizophrenia. However, the caveat is that we first need to replicate these findings in larger, more diverse samples before considering how these variables might be used to inform the treatment of patients. So thank you all for listening. I just wanted to quickly thank all my supervisors for their help, everyone at Cardiff who I work alongside for being so great, and of course Mental Health Research UK for giving me the opportunity to work on this exciting project. Cheers.